Dear colleagues, dear friends, welcome to today's EACVI webinar on the highlights from the EuroEcho 2019 that was held in Vienna in December. I am Professor Tor Edvardsen from Oslo University Hospital, and I'm your EACVI president. And I have the pleasure of being joined by Professor Bernard Cosyns from University of Brussels in Belgium. He is the president-elect of the EACVI. And then we have Professor Maurizio Galderisi from Federico II, University of Naples in Italy. He is the vice president of the Echo section. The aim of this webinar is to cover some of the highlights from the EuroEcho conference. The conference was a great success and had around 4,100 delegates from around 100 countries around the world. We had lots of excellent sessions and lots of new studies presented there. One of the most popular sessions at the EuroEcho is the highlight session, presented on Saturday. The best abstracts from the conference are presented during this session, and Bernard and Maurizio will present some of those today. We will also present a couple of MCQs during Mauricio's talk, and I also invite you to send your questions throughout the whole webinar and also your comments, and we will address some of those during the webinar. I will now hand over to Bernard for his presentation. Please, Bernard.
Thank you, Tor. So it's a pleasure to be here. I have to say that it will be a little bit frustrated for the abstract presenter because this is a selection of the selection. We had a lot of very good content, and I will address three different topics. The first one is the new technologies. This topic was presented during the Congress by Maja Sikes from Croatia. And I will begin immediately with the first subtopic, which is about myocardial work in CRT. As you may know, so the septal work is already used since several years from now. But here in this original study, so the authors combined the presence of septal wasted work with the presence of viability identified by late gadolinium enhancement at CMR. And you can clearly see the example of a patient here. If you follow my arrow, before CRT, he has this typical septal flash with strain, and you can clearly see on this pressure strain loop the negative work at the level of the septal segments. You can also clearly see that this patient had no fibrosis and full viability. And this is the results of the patient after 6 months of CRT. So no more septal flash, a normal pressure strain loop, a decrease in the negative work, and this is a very nice predictor of the CRT response if we define it as an increase of more than 15% reduction of the left ventricular and systolic volume at 6 months. This means that the combination of these two parameters should be a nice target for predicting the response to CRT. Another interesting new technology is the ultra-high frame rate in cardiac ultrasound. And in this particular study by Petrescu and colleagues, they aim to investigate if natural shear wave velocities increase with the degree of diffuse myocardial fibrosis and with invasively determined left ventricular filling pressure, as reflection of an increase of this myocardial stiffness in heart transplant patients. So they address 46 patients. They, of course, perform standard echo, shear wave elastography using the high channel density programmable ultrasound system dedicated. And also all the patients underwent right heart catheterization for the measurements of the pulmonary capillary wedge pressure. They also performed some CMR in these patients with a T1 mapping in order to assess the presence of diffuse myocardial fibrosis. You can clearly see in these 3 different patients with an increasing amount of fibrosis that the velocity regarding the tissue acceleration provided by the M mode is increasing. And if you look at the figures, you can clearly see that, in fact, the shear wave velocity was the best parameters in terms of correlation with this importance of the diffuse fibrosis. In the same way, you can clearly see that the pulmonary capillary wedge pressure was best correlated with the presence of the native T1 mapping, so diffuse myocardial fibrosis, and also correlated with the shear wave velocity. So this means that potentially this technology may help us to better define the presence of diffuse fibrosis at the level of the myocardium in heart transplant recipients, but also maybe a new way to assess diastolic function in all the patients. Using the same kind of technology with the single heartbeat for the ultrafast echocardiography, Papadacci has shown that you can, in a very short period of time, acquire more than 5,000 segmented volume, but also Doppler volumes, so propagation of the flow, but also tissue Doppler volumes. And doing that, you can, in fact, get all the information. So in 1.2 seconds, you have a very high number of data. And this correlates perfectly with the standard measurements of the Doppler indexes, the volumes assessed by 2D echo, but in a very shorter period of time. And of course, this means also that not only you have all this data on top of the classical data, but it's also a unique features by enabling simultaneous hemodynamic assessment during the same heartbeat. And finally, it means that this has the potential to improve the patient care because you can accelerate the examination time and, of course, improve the reproducibility. We had also, of course, we cannot avoid that, a lot of presentation regarding machine learning. I picked up only one, and this is in a pediatric population and of dilated cardiomyopathy. And what they did, they integrated 15 clinical parameters with the standard echocardiographic descriptors like the flow, but also strain curves. And they put all these data in an unsupervised multiple kernel learning algorithm. And they provide us with an output representation, and they also went to a clustering wise even rates. So you can cluster the patients depending on all these parameters in function of what will happen to them. And what they were able to show, and you have here three typical examples of patients with similar characteristics in terms of curves, that the cluster 3 had a very low even rates and death rates compared to cluster 3. So you can cluster these patients in terms of the outcome. And integrating all the parameters in function of the cluster, you can see how much have also comorbidities or abnormal clinical parameters. And this is the perfect illustration that by integrating the echo parameters and the clinical parameters, you get more information about the outcome of these patients. Finally, we had also a very nice presentation on artificial intelligence. And I picked up this particular one from Paris, showing that if you take 40 healthy volunteers and you ask to 40 novice sonographers to perform an echocardiography, and you compare that with expert sonographer, and then you give a 10-minute theoretical training to look at the initial results of the transthoracic echo, you can also ask to them to be assisted by artificial intelligent algorithm, so the automated view recognition, for example. And finally, you give them a second chance to repeat the echocardiography. And this is the results in terms of global performance if you compare to the experts. And you can see in blue here that in terms of quality and performance, you have a better results if you use this assisted artificial intelligence algorithm compared to the initial transthoracic echo. And it's even better if you give a training to these novices and you give them the chance to repeat the examination. Moreover, only artificial intelligence algorithm was able to decrease the time of acquisition. This means that not only this will change our way to, I think, learn and teach echocardiography, but also that using this kind of algorithm, we may expect to have a better standardization of the acquisition in the next future. So I don't know if you have any questions before I move to the next topic regarding valvular heart disease from yourself, Maurizio. I don't know if you have any questions about this.
Sure, Bernard, there are lots of questions coming in. I'm going to organize and ask you afterwards, but I have one burning question. You mentioned one example on how you can bring artificial intelligence and machine learning in one patient. But in general, how can you bring it down to one single patient instead of so we can use it for a patient-specific treatment and diagnosis instead of the evidence-based things we are used to with hundreds of people and patients?
Yeah, I think it's a very interesting question, and I'm sure that I will be able to address this question in one of my next presentation. So indeed, I think artificial intelligence will allow you to, as I shown, improve the acquisition, to standardize it, to improve the analysis, but also to help us in the management of the patients, in the treatment of the patients. And if you have this kind of output space with all the characteristics of the patient, if you have a new naive patient, you can of course compare with the different types of patients in the cluster, and then you can immediately, almost immediately, get the answer about the outcome of these patients. So I think at the individual level, you can project it on new patients in this output space and get the information.
So your idea is to bring it into the machine, the echo machine, and then immediately spit out to the imager and give feedback? Or do you need some minutes or hours to sort of...
I think at this stage it can be done immediately, but of course we need validation for that before it's entering in the clinical arena, of course.
Mm-hmm. If I can jump in the discussion, it is important that you, Bernard, will lead a task force of European Association of Cardiovascular Imaging on artificial intelligence application in cardiac imaging and echocardiography, and I think it is an important task.
Yeah, absolutely. I think it's very exciting because I think this will be an important game changer in the next following years regarding a lot of things. And this will for sure change our practice, change the way we are conducting research, education, we are communicating, and this will raise a lot of challenge regarding privacy, the management of the data. I think it's really exciting, but we have a lot of work, and indeed we will work hard, and we begin to work this month, to be honest. So I think indeed it's a good point. Thank you, Maurizio.
Yeah, I'm sure we will return to artificial intelligence during this webinar at a later stage as well. So you may continue on the valvular heart disease.
Yeah, this is a completely different topic. It's about valvular heart disease. This was presented by Julien Magne from Limoges. And the first subtopic is about aortic stenosis. You probably all know that, of course, aortic stenosis will create an adaptative, eventually inadaptative left ventricular hypertrophy and an increase in the left ventricular mass index. And the questions raised by this group of authors is there any relationship between this mass and the measurements in the left ventricular function, including strain? And they also had a quick look on not only on the global longitudinal strain, but also to the other type of strain, the radial and the circumferential one, and to look at what happens with this strain in patients with preserved ejection fraction. So for that, they have studied more than 100 patients with various degrees of aortic stenosis, and then compared that to 20 age and gender matched healthy controls, using the TomTech software to do that. And this is the main important findings. If you look at this very nice graph, three-dimensional graph, and you take the patient with an ejection fraction above 50%, and you look at the progressive increase in the left ventricular mass index, you see that the GLS, the global longitudinal strain, increased to a certain point. But afterwards, there is a drop of the GLS, and it seems to be compensated by the global radial strain. And this is a very interesting finding, because this means that maybe in patients in whom you have hypertrophy and you have a decrease in the global longitudinal strain, if you see that there is a progressive increase in the global radial strain, this is maybe a parameter that can indicate in asymptomatic patients, for example, that the patient should be operated before you reach no return point. Regarding tricuspid regurgitation, we had a massive amount of abstracts on that, so it's no more the forgotten valve. I picked up some studies, and this one is for me really important. It's coming from Padua, from the group of Luigi Badano and Denisa Moharu, and you can see that they aim to look at different quantitative parameters to grade functional tricuspid regurg severity, and this by conventional echo, and to look at the prognostic value. So it's of course a single center retrospective observational study, almost 300 patients with at least mild functional tricuspid regurgitation, with reasonable follow-up, and the outcome was death and hospitalization for a right heart failure. And clearly, you can see that they can define cutoff values for the vena contracta as severe when it's more than 6. For the effective regurgitant orifice area, more than 0.3. And for the regurgitant volume, more than 30. Regurgitant fraction, more than 45%. And you can see in this graph on the right panel hand side that these values are quite discriminant compared to the others regarding the predefined endpoint. So it means that probably we have to rethink a little bit the way we are quantifying or we are assessing the tricuspid regurgitation. And also a very interesting point is that the values provided by this particular study are lower than what we have in the guidelines. So maybe it's time to rethink about these new values within the guidelines. Again, about tricuspid regurg and the right ventricular function, very shortly, this study from France showing that we have to look at the tricuspid annulus diameter, but not only. And in this study, they try to characterize the determinants of tricuspid regurgitant severity in stable patients with preserved left ventricular ejection fraction without left ventricular heart disease. And they classified the patients in 5 different groups according to the tricuspid regurgitant severity. And what you can see is that there is a progressive increase in the annulus of the tricuspid valve among all the grade of severity of the tricuspid regurgitation. All of them were surprisingly above 35, but most interestingly is that in fact there is no correlation with the right ventricular function. So it means that early enlargement of the tricuspid annulus may be present in secondary isolated tricuspid regurgitation. And so without any dysfunction of the parameter, we don't have any correlation with the function of the right ventricle. So it means that probably we have to find another way to assess both tricuspid regurgitation but also right ventricular function. Finally, very interesting study regarding bivalvular regurgitation. So as you may know, the concomitant presence of functional mitral regurg and functional tricuspid regurg is not infrequent. And actually, we don't have too much data about to treat these patients. It remains quite challenging. And in this presentation by Eitzinger and colleagues, they recruit more than 1,000 patients with heart failure with reduced ejection fraction with a follow-up of more than 5 years. And interestingly, they were able to show that it represents 30%, more than 30% of the population in this cohort. And if you look at this graph, you can see that if the patient had both moderate tricuspid and functional mitral regurgitation, the prognostic is worse than if they have isolated pathology at the level of or the mitral or the tricuspid valve. And also they were able to show that they had more symptoms, high hormonal activation and more remodeling. So this also is represented by these Kaplan-Meier curves. You can clearly see that a patient with multivalvular severe functional regurgitation have a worse prognosis compared to isolated severe functional regurgitation or non-severe functional regurgitation. On the right panel end side, it's clear that, so in fact, multivalvular moderate functional regurgitation has a similar prognosis compared to isolated severe functional regurgitation. So meaning that we have to take this into account when you treat these patients. Now, I will move briefly to prevention. Maybe you have some questions, both of you, and you can interrupt me, feel free.
Yeah, Bernard, we had some questions from those who are watching us, and one question was to address, can strain help us for sort of timing surgery or intervention of aortic stenosis? You didn't quite touch that, but do you think the combination of strain and artificial intelligence, or could you do it even today?
No, actually, as you may know, we have produced with the EACVI meta-analysis stating that global longitudinal strain may have an added value to detect subclinical dysfunction in patients with preserved ejection fraction and asymptomatic aortic stenosis. Of course, there are some drawbacks related to strain, whatever the type of strain it is, so the longitudinal but also the radial strain, which are related to the change in the load, the afterload, and we know that this may influence the strain. So some authors also suggest to report some kind of ratio based on the strain values and the end diastolic volume indexed in order to tackle a little bit this load issues. But actually, it's still, I think, a matter of debate. So I could not recommend at this stage to use global longitudinal strain or another type of strain. Nevertheless, I think we have some indications that it could be interesting to use, and we need probably more information about it before using it definitely in the clinical practice.
So a couple of more years studies to sort of
probably
to wrap up and conclude.
Myocardial work should also maybe an option.
Yeah, that was also a question about myocardial work and aortic stenosis. Can you use it in patients with aortic stenosis? That was the question.
I have personally no experience. I don't know if you have, but theoretically, why not?
There is a gradient, so we have to sort of. Do you have any experience?
No, I have not experience, but we are planning to do a study. Probably we need to add to the cuff or blood pressure the gradient, the transvalvular gradient. But I think that we should need to validate this model against cath lab measurements.
So we might return and address these questions from this gentleman next year or in a couple of years.
Yes,
we can have his answer.
I think yes.
Yeah. Sounds good. And then prevention.
Prevention, so presented by Elif Sadeh. So I picked only for the sake of time 2 topics. The first one is about the left atrial remodeling and stroke. This is a sub-study from the ERIC NCS study presented by Dr. Bianco and colleagues from Boston and also Italy. What they did, in fact, they were looking at patients stratified in function of the brain MRI, and they had 3 groups, no cerebral infarct on MRI, or subclinical infarcts, or clinically diagnosed stroke. They end up, so the study with almost 500 patients, and they did an analysis based on the strain of the left atrium. And interestingly, they found that there was an association between this left atrial strain and the increase of all type of stroke. They also were able to show that if you take the E over E prime divided by this left atrial global longitudinal strain, which is supposed to be an index of atrial stiffness, it is also associated with both subclinical but also clinical stroke. So this is very interesting because this means that you have not only to rely on the Schätzwas score, on the fact that your patient is in sinus rhythm, and I want also to take the opportunity to say that actually Maurizio, correct me if I'm wrong, is preparing a study examining the atrial function in this kind of patients too.
Sure.
So I move to my next topic, which is the last one, and this is a study coming from Barcelona, and they have explored the hypertensive patients, and they have looked at the Doppler profile, but also the full myocardial deformation, and they have applied also a machine learning approach, and this will probably also answer to your first question, Tor. So they have used this machine learning to recognize the patient profile in hypertension without relying on clinical measurements and parameters, but by learning from subtle differences globally present in velocity and deformation echo data. So they have studied almost 200 patients. They have applied this machine learning input, and they have created an hypertensive output space. And based on a clustering, they were able to also to classify the patient in terms of risk of remodeling and higher risk of events. As you can see here, so you have a clustering of this patient. You can see that there are some I think distribution among this dimension space, output space, and clearly some patients will have poor outcome in terms of remodeling, so are more at risk to have some events. And if you look at the healthy controls, you can see that they are clearly in another part of the output space. And what is really interesting, to make it short, is that if you have a naive patient, based on these subdivisions, you can clearly place your patients in the good category. So at risk of having left remodeling, but also to have more events. And this is, I think, somewhere an answer to your question. So an individual patient can beneficiate for this kind of analysis. And I think now it's time to give the hand to Maurizio.
Well, I might have a question for you before we leave the word to Maurizio. Some cardiologists and some imagers are afraid of digital health, artificial intelligence, machine learning. They feel sort of threatened by those techniques. What is your opinion, Bernard?
Yeah, I think it's also reflected if you type on Google, artificial intelligence will replace, and then you have the suggestion from Google, which is somewhere also artificial intelligence, by the way, and you will see that the first line is will replace doctors.
Uh-huh.
Yeah, yeah. Look at
Wow.
this. It's
Okay.
very funny. So it means that, okay, I think it's a general feeling. We should not be afraid. I think we have to be proactive, and that's why I think we need to have this task force to address all these issues, because it's already present. It's the moment, and we could quote maybe Victor Hugo in saying that if you are at the good moment, it's a time to move forward.
Mm-hmm. Yeah, and I think we have to. And now I turn to Maurizio. You are giving your part of this highlight session.
Thank you, Thor. It is my distinct honor to be here with the President and the President-elect European Association of Cardiovascular Imaging, and I will deal with two topics in this highlight: heart failure and acute cardiac care, which was one of the two main topics of the Congress. And the heart failure contents included main topics such as artificial intelligence, myocardial work, shear wave propagation, vortex formation, strain imaging, standard echo Doppler exam, a multimodality approach to cardiac disease. And indeed, several of these abstract and presentations was really nice and interesting. Unfortunately, I will deal with few of these presentations. And first of all, the multi-parametric assessment of diastolic function in heart failure from a Japanese group of Tokyo. And looking at the study design, you can see that a cluster analysis based on unsupervised machine learning algorithm was compared to the diastolic grading performed according to current recommendation on diastolic function. And the primary endpoint was the hospitalization for worsening ejection fraction. That means that this study assessed the impact of artificial intelligence on diastolic function assessment. During the follow-up period of 2.6 years, 62 patients experienced the primary endpoint. And looking at this part of the slide, you can see that the cluster-based classification worked much better than the classical standard classification obtained by guidelines, and also provided a significant improvement in the prediction of the events, not only in comparison with the clinical score and left ventricular and diastolic diameter, but also in comparison with the classification obtained by standard classification of guidelines. Therefore, machine learning techniques show an incremental value in comparison with current guidelines for stratifying the risk of decompensation in heart failure. This second study is also based on the use of artificial intelligence. In this case, the author evaluated the accuracy and the reproducibility of an artificial intelligence-based semi-automated tool to compute left ventricular volumes and ejection fraction in comparison with manual tracing using cardiac MRI as the reference gold standard. Looking at the study protocol, you can see that 3 different observers, one first senior observer, one second junior observer, and a third senior observer performed the measurement of left ventricular volumes and ejection fraction based on manual tracing and also the artificial intelligence-based model. It was a retrospective two-center study, and the gold standard was, as just mentioned, the cardiac MRI. The artificial model training was based on the acquisition of more than 700 apical 4-chamber and 2-chamber views, and the statistical analysis was polarized to assess the concordance between the two methodologies. You can see mean distance and mean signed distance. And looking at the result using CMR as reference, you can see that the accuracy of both ejection fraction and volume was greater by using artificial intelligence model, and also important, looking at the narrow range of the measurement among the 3 observers, you can see that also the reproducibility was much more better by using artificial intelligence than manual tracing. Therefore, this study demonstrated an improved accuracy and higher reproducibility of left ventricular volume and ejection fraction by artificial intelligence in comparison with manual tracing. Now, I will launch the first MCQ, and please reply during the running of the slide. The query is, can artificial intelligence improve the reproducibility and consequently the accuracy of transthoracic echocardiography in the clinical practice? First possibility, yes, artificial intelligence can improve the reproducibility of echocardiography of both acquisition and reading procedures. Second, yes, artificial intelligence can improve the reproducibility of acquisition procedures. Third, yes, artificial intelligence can improve the reproducibility of reading procedures. 4, no, artificial intelligence cannot improve the reproducibility of echocardiography, and author will collect the response.
Thank you, Mauricio. We have still 12 seconds to wait for the answer. What is your feeling, Bernard, for this?
You want to cheat and to give the answer?
Yeah, sure.
No, I think this point out that artificial intelligence, and I think it was already pointed out by the previous presentation, is broad range of, I think, different things. But one important point is that, of course, improving acquisition is a crucial point, because if you have an algorithm which is some kind of black box, you need to have good data. And data acquisition the quality of the data is for sure a big issue regarding artificial intelligence. I've heard, I think it was Professor Rademacher saying that if you have garbage in, you have garbage out. So if you have a good algorithm, but you have bad quality of data, you will get bad results, of course. So in my point, of course, it's important to have both of them, acquisition and readings. I don't know the opinion of the attendants.
Well, by now is 69% responding that artificial intelligence can improve both acquisition and reading procedures, and then only 10% for the left. So I think that was what along your opinion as well, Mauricio?
Yes, it is my opinion, and I think that this reply is encouraging, because it means that the perception of artificial intelligence in the imager community and in the echocardiographic community is good, and it is obviously very good to improve and implement this kind of assessment in the next future.
But we cannot trust every response from machine learning and artificial intelligence. Garbage in is garbage out, that's for sure, like Bernard said. And my feeling is that you mentioned also diastolic function, and that's challenging without any assistance, without any help. And then you put a lot of parameters into a sort of black box, and then you sort of shake it or steer it, and then you get an answer. How can you believe, or how can you trust?
Yes, you are right conceptually, but it is important that in the study that I mentioned, the prediction of the events was improved by applying artificial intelligence, and it is probably the real meaning of this task of artificial intelligence, and as also Bernard mentioned, that means to improve the risk stratification and therefore the management of patients by applying.
So studies should be designed with an outcome,
yes,
like mortality
outcome,
or myocardial infarct or heart failure by some hard parameters. So that will give you the final answer if it works?
Yes, the study I mentioned tested the heart failure, hospitalization, and cardiac death. That means two important endpoints.
Might also be important maybe to mention there are different types of machine learning, supervised, unsupervised, and also yes, other ones with whether the algorithm can take into account its own error. So I think this is, of course, an additional challenge, which algorithm, type of algorithm to use. I think there are different purposes, and this will be also a very exciting challenge to address in the next future.
For sure.
There are so many companies out there who wanted to sort of earn money on these topics and functions, so we have to take care, and we look forward to have your final answer from the task force, Bernard. It will.
Well, one of the sub-task force will, of course, address the relationship between, of course, the patients, the imagers, and the companies. And we have a sub-task force on that, and also to address the ethical issues, yes, about the privacy, who is the owner of the data, and so on. So I think a lot of work in perspective, yes, indeed.
It's an important task, a good balance to find about these different aspects. Work in progress.
Yep. Okay.
Okay, I can keep going. This other presentation is nice, is the acute redistribution of regional left ventricular work by CRT and long-term remodeling. The background is obvious because does acute work change by CRT link to remodeling? Indeed, We know that left bundle branch block induction in animals determines acute work redistribution and start remodeling. Therefore, does TRT then acutely change work? Does DIN then trigger reverse remodeling? The design of the study was really very simple because left ventricular volumes and regional work were evaluated pre-CRT at the time of CRT, 1 week after CRT, and finally the changes of left ventricular and systolic volume, that mean reverse remodeling, was evaluated 1 year after the procedure. And you can see in these slides that if before CRT, part A of the figure, myocardial work showed a significant difference among left ventricular work, when CRT was in function, part B of the figure, it induced an acute myocardial work redistribution with a most increase in the septum of the work and most decrease in the lateral wall. That means that the changes of loading condition can be important to influence the process of the remodeling. And in fact, we have that the acute difference of the redistribution of the work between lateral and septal wall was strictly related to the left ventricular reverse remodeling at 1 year of follow-up. Therefore, the take-home message of this work is that the acute redistribution of the myocardial work can be important to predict the left ventricular reverse remodeling at 1 year, and this data suggests that the mode of action of CRT is strictly related to the redistribution of regional myocardial work, that means of loading condition in the heart. This is the last presentation of our failure, and you can see that in this study, this Polish author compared the well-recognized sudden cardiac death risk calculator proposed by European Society of Cardiology, where 3 echocardiographic parameters are included, with new predictors. Please take into account that in the standard risk calculator, left atrial size is measured by considering left atrial dimension by a mode echocardiography. Conversely, the authors of this study proposed the replacement of left atrial diameter with the left atrial volume index and the inclusion in the algorithm also of left ventricular longitudinal strain. Therefore, this study evaluated the impact of left atrial volume and strain imaging on the calculator of sudden cardiac death in hypertrophic cardiomyopathy. And looking at the result, you can see that by this modification, the novel model was significantly related to the outcome more significantly than the old calculator. Therefore, the proposed new sudden cardiac death risk factors, left atrial volume index, longitudinal strain, should be taken into account when considering the implantation of ICD. Globally, if we consider all the contents on heart failure, we can tell that the application of artificial intelligence appears to provide an important additional value to echocardiography in terms of reproducibility and accuracy. Strain imaging can have still margins of improvement in terms of the outcome prediction in the heart failure setting, and myocardial work can even improve the diagnostic capabilities of strain imaging in heart failure by adjusting for afterload. Before keep going, Tor and Bernard, if you have some observation to do.
Yeah, there are some questions about myocardial work, and would you say it's ready for clinical use, or what do you miss to sort of convince all the echocardiographers before they can use it?
I think that the use of myocardial work is ready because it is well demonstrated in some clinical settings such as coronary artery disease, resynchronization therapy, and also arterial hypertension and some cardiomyopathy, that it can make the difference. Because we know that one of the limits of the strain imaging is the dependence of the load, and by using the myocardial work application we can adjust for changes of afterload, and this is important to solve one of the limits of strain imaging.
Do you think we need to adjust also, let's say, for blood pressure when it's in the sort of normal ranges of systolic blood pressure? Do you need to adjust for it?
I think that this is an important point, and there are some studies which demonstrated that in patients with arterial hypertension, the higher blood pressure increases the constructive worth. And this is important because probably it is an up-tempo compensation by the heart to keep the function in the normal range.
Mm-hmm. All right. Do you have comments, Bernard?
No, maybe a short comment about the left atrium in hypertrophic cardiomyopathy. Probably that the calculator provided by the ESC is taking the LA measurements in M mode because it's more reproducible than if you have to use the volumes in 2D, because you have to proceed to different measurements in different incidences. And maybe is the 3D there the possible answer to have a more reproducible measurements.
Yes,
just a suggestion.
And also because indeed I explored this topic, there are not evidence on the use of left atrial volume index till now in the setting of hypertrophic cardiomyopathy. So the calculator is based on the evidence, as all the guidelines do, and probably it is the main reasons for which it was preferred to use the left atrial diameter. But this study indeed opens new horizons on the use of left atrial volume index.
For sure, because we know that the dilatation of the left atrium is not only in the transversal dimension, but also in the longitudinal dimension, so it might be, of course, of added value.
Yes.
Yeah, it's sort of hard to image that one line could be extremely a good measure, actually.
Mm-hmm.
At least you can, it's logic that sort of circumference and volume should be better, and perhaps 3D is the answer.
Yes, 3D could be the gold standard, probably.
Yeah. So Mauricio, I suggest that you keep on.
Yes.
With the rest of your...
And now I will move to the part of presentations which involves the study on acute cardiac care, and I need to thank Susanna Price from London, who take care of this part of presentation also in Vienna. And the first study is the myocardial deformation imaging after STEMI. Can we better predict 1-year mortality and heart failure development? In this study, the authors used left atrial and multi-layer left ventricular strain, and going on the result, you can see that the sensitivity of these parameters that are longitudinal strain and the circumferential strain on mid-wall layers, and also the left atrial strain had the best sensitivity, whereas the best specificity against the prediction of major cardiac events was shown by radial strain of atrial contraction, whereas left ventricular ejection fraction failed to predict accurately the major cardiac events. Therefore, multi-layer strain approach can be more useful than standard echocardiography to stratify prognosis after STEMI. These other two studies, this one and the subsequent, are similar because tested by cardiac MRI, left atrial and left ventricular function in STEMI patients by calculating left ventricular function deformation, that means global longitudinal strain and global circumferential strain and global radial strain as well, and left atrial deformation by calculating in apical 4 and 2-chamber view left atrial reservoir function, left atrial conduct function, and left atrial booster pumps. The major cardiac events were evaluated after 1 year. And you can see that, importantly, independent correlates of this event were in LAD lesions, not only the number of diseased vessels, and it could be largely expected, but also left atrial reservoir function. And in a lesion of circumflex artery, the KILIP class, that means a clinical evaluation, and also left ventricular global longitudinal strain, predicts the events. Therefore, these findings highlight the independent prognostic role of strain imaging, which can represent novel therapeutic targets in acute cardiac care. This other study is similar, and indeed the authors tested right atrial function in acute MI, again by using a cardiac MRI, and right atrial function deformation was analyzed in apical four-chamber view for evaluation of right atrial reservoir function, right atrial conduct function, and right atrial booster pump function. Again, the prediction of the events was at 1 year. And you can see in these slides that reservoir and conduct atrial strain, but not booster strain, predict the events after acute myocardial infarction. And now, Tor Bernard, I have the second MCQ. Please go to reply. Can strain imaging improve the risk stratification in acute coronary syndrome? First, yes. Atrial and ventricular strain components can improve the risk stratification in acute coronary syndrome. Second, yes, all left ventricular strain components can improve the risk stratification. Third, yes, but only longitudinal strain can improve the risk stratification. Four, no, strain imaging does not improve the risk stratification in acute coronary syndrome. Please, Todd.
Great. There are 20 seconds left for your response. What are your feelings, Mauricio? Do you think people out there use strain?
My feeling is that
coronary syndromes,
yes. My feeling is that this measurement can be obtained obviously also by echocardiography, and in particular left ventricular global longitudinal strain and regional strain are very feasible and reproducibly also in the acute care unit. And so I think that their value, which is also well recognized, should be developed also in guidelines.
Mm-hmm. So we have the responses. So I start with no. How many do you think answered no?
I don't know.
3%. 3%.
Ah, okay.
So they are believers. So you did well, Mauricio, but I think you are correct. And this weekend I will also have a talk on the French Society of Cardiology on how we can use strain during acute coronary syndromes, and 70% agree with you. You can use both atrial and ventricular strain components in risk stratification in acute coronary syndromes. So we still have some minutes, so you can continue.
Okay, I will strictly close. This is the last study I will present, and practically in this study a periodontal index, which is an index of the state of the periodontitis, was tested against markers of coronary involvement by coronary CT, and you can see that the higher this index, the higher the total calcium score, and a good relation of periodontal index with plaque composition was also fine. Therefore, markers of inflammation such as periodontal index predicts coronary artery structural damage. And now, concluding my highlights on acute cardiac care, summarizing the results of this study, I would like to mention that beyond ejection fraction, the evaluation of strain imaging can substantially improve the outcome prediction in acute cardiac care. The evaluation of the left atrium and right heart shall be considered when dealing with acute coronary syndromes. Phenotypic variation matters in acute cardiac care, and inflammation markers are important to predict coronary damage.
Thank you, Maurizio. We have some questions that I think we should address. We still have some minutes. Before those questions, I think I will remind all of you that this year, we have EACVI 2020 conference that will happen in Barcelona in December, in Spain, from 9th to 12th of December. And this will be a multimodality conference with all the most important modalities: CMR, echocardiography, CT, and also nuclear cardiology. And I'm sure that we will return to artificial intelligence also in those abstracts and in that conference. And many comments have also requested interventions. And I think the EACVI 2020 will also be a big and important opportunity to have some answers about how to do interventions, because that's a burning topic these days. And we have also started and initiated a task force on that. So we will return to you in Barcelona. Here's one from Naples, Maurizio. One question. I won't tell his or her name, of course, but he or she is asking, does the echocardiographic longitudinal strain have the same predictive value as the CMR longitudinal strain?
I can tell that yes, because the majority of the study in the setting of acute coronary syndrome were performed by using the global longitudinal strain performed by echocardiography. And I would also add some consideration that by using the strain imaging, the group of Thor and Christina demonstrated that also the dispersion of the regional strain, that is the timing to achieve the maximal strain, can be important to predict the arrhythmic events after myocardial infarction and in the acute setting of acute clinical care.
Yeah, so you are an echo believer. But I think also it's quite fascinating that lots of CMR studies are coming up now with strain techniques as well.
I think that the great advantage of echocardiography that we can do on the bed of the patient bed, and it is important in the setting of the acute coronary syndromes.
It's very quick. Then I turning to Bernard. We had some questions about valvular disease and also about right ventricular function. You touched upon right ventricular function, didn't you? And one statement is that TAPSE is the best RV function measure. Do you agree?
Well, I think it's a reliable technique. It's reproducible, it's simple, it's easy. But it's not the best one, of course, and especially in patients with massive or elusive tricuspid regurgitation, because, of course, you have a sur-evaluation, an over-evaluation of the right ventricular function. And so, therefore, I think you miss the target, saying that just looking at a TAPSE, even if simple and reproducible method, you have a good evaluation of the right ventricular function. And I think that's why probably we have this, discordance between the dilatation of the tricuspid annulus and the evaluation of the right ventricular function. And I just want to underline that there was a very nice study published in the Journal of the Association recently, looking at the evaluation of the right ventricle by 3D, and I think it is probably also the way to go in the next future year. It needs some fine-tunings. There are still some things and that should be, of course, improved, and especially the reproducibility. But I think, once again, with all these technical progress, we can hope that in the next following years, we will have, reliable tools to assess better the right ventricular function than with the TAPSE.
Mm-hmm. Okay, so I guess we are approaching the end of this webinar, and I would like to close this session by summarizing some of the key messages that I heard. Artificial intelligence, machine learning might become a game changer during the next years to come for the management in clinical practice and treatment, perhaps, and also risk stratification of your patients. We have to see, of course, for more studies. And then also new echo parameters like strain, myocardial work will help you to guide treatment of asymptomatic aortic stenosis and also guide you in the difficult decisions on the tricuspid valve. And also, as Mauricio just told you, use strain imaging in your daily practice. So I want to thank Professor Bernard Cosyns, thank you, and Professor Mauricio Galderisi for their great presentations. You have lots of gratitudes here coming in. And to learn more on these topics, please feel free to save the links that are currently displayed in the interactive timeline that you can see. You will be able to watch this seminar on demand on the EACVI website in a few days. So thank you all for watching us. Thanks.
It was